to discuss here about very high yield MCQs. So MCQs on prolactinoma and hyperprolactinemia. So pituitary macroadenoma refers to the size of tumor less than 1 centimeter, more than 1 centimeter, less than 1.5 centimeter, or more than 2 centimeter. So guys, this MCQ is very important for exam point of view. 10 millimeter equals to 1 centimeter, remember. So if they ask microadenoma less than 10 millimeter or less than 1 centimeter, but here macroadenoma, that means more than 1 centimeter is answer here. So the single best answer here is more than 1 centimeter is considered as pituitary macroadenoma. Okay, one more MCQ in exam they like to ask between hyperprolactinemia and prolactinoma. So more than 200 value is considered as prolactinoma. Next question. 23-year-old female with secondary amenorrhea, galacturia, bitemporal hemianopia. MRI shows tumor 30 millimeter. What is treatment of choice? So more than 10 millimeter is considered as macroprolactinoma, and we can say this is around 3 centimeter. So how to treat bitemporal hemianopia due to compression of nearby structure? So guys, treatment of choice in prolactinoma, any case, go with option is bromocriptine, surgery or radiation or all. So guys, first option, you have to do medical treatment, bromocriptine. Bromocriptine is drug of choice in case of pregnancy, patient with prolactinoma. Also cabergoline is a drug of choice in case of males with prolactinoma. So hope it's clear. Now next question. True about prolactinoma in pregnancy, all except most common tumor in pregnancy and asymptomatic, size of tumor increase in pregnancy, increased prolactin level require regular monitoring, macroprolactinoma more than 10 millimeter lead to optic chiasma compression and bitemporal hemianopia. So let's discuss all options together. Most common tumor in pregnancy and asymptomatic, yes. So this is true statement, so this is rule out. Size of tumor increase in pregnancy, this is also true statement, so rule out. Why? Because they are asking accept. Macroprolactinoma more than 10 millimeter leads to optic chiasm compression and bitemporal hemianopia, this is correct statement. But prolactin level require regular monitoring, this is false. In pregnancy, false, because if you monitor prolactin level in pregnancy, always we find there is increase in prolactin level and we are not able to identify this prolactin is high due to prolactinoma or due to pregnancy. That's why prolactin level is no value in pregnancy, so C option is right. Now 7-month pregnant female, history of prolactinoma. 7-month pregnant female, history of prolactinoma, present with headache and bitemporal hemianopia. How to treat? What is treatment of choice? Induction of the delivery, start bromocriptine, surgery or radiotherapy. So guys, in spite of pregnancy or normal prolactinoma, if they ask treatment of choice, always medical treatment. In pregnancy, drug of choice. In prolactinoma is bromocriptine. Start with bromocriptine. Start this bromocriptine for 4 months in pregnancy and then see symptoms are disappear or not. Then only if symptoms are not disappear, then surgery is indicated, otherwise no. Macroprolactinemia refers to, this is different. This is macroprolactinoma we discuss, microprolactinoma we discuss. This is a case of macroprolactinemia refers to. So about macroprolactinemia, I explained in my subscription program in very well detail. So pituitary adenoma more than 10 millimeter. This is not. Why? Because this is not prolactinoma. This is prolactinemia macro. A large polymeric prolactin molecule. Pituitary tumor more than 4 centimeters with increased prolactin. This is false statement. All is false. Answer here is large polymeric prolactin molecules. What happens in macroprolactinemia? Prolactin level is very high, but patient is asymptomatic. Okay. Now, 23-year female on haloperidol for schizophrenia present with amenorrhea and galacturia. Found increased prolactin level 70 microgram per liter. If more than 200, then we consider a case of prolactinoma on the basis of MRI findings. But 70 is drug induced. Hope question is clear. Haloperidol induced prolactinemia, and patient is schizophrenic, present with amenorrhea. Galacturia means patient is symptomatic and increased prolactin level. So what is your next best step when patient is drug induced hyperprolactinemia, means increased prolactin level in blood and patient is symptomatic? Option A is recheck prolactin in dilution, start gabagoline, C stop haloperidol and the prolactin after 3 days, switch to atypical antipsychotics. So guys, in spite of atypical antipsychotics, they also raise prolactin level. So no use of starting atypical antipsychotic here. And start gabagoline is not a right option. Recheck prolactin in dilution. Stop. First best step, if you find drug induced hyperprolactinemia, stop haloperidol. Stop any drug, offending drug. Then measure prolactin level after 72 hours. After 72 hours, prolactin level comes down or sometimes it's normal. That means this is a case of drug induced. If prolactin level is not reduced in spite of stopping 72 hours, then do MRI also to rule out there is prolactinoma or not, in spite of macro and micro. Or in exam, multiple times they ask drug induced hyperprolactinemia. What is drug of choice? That is trihexyphenidyl, benhexol we can say. So guys, I hope till here it's very much clear. And if you want to study hyperprolactinemia and prolactinoma in very much details, then subscription program I provide 800 high-yield videos. One video, one topic is prolactinoma, hyperprolactinemia, single video, 10 minutes I finish. And that program, subscription program price is 7,000. More than enough to score excellent rank in any exam. Thank you.